welcome to the next episode of my science podcast. Today I'm really delighted to welcome Professor Lady Heather Cubie, who is a retired consultant clinical scientist, and she's done work on the use of new molecular technologies for diagnostic virology and molecular pathology. She's specialised in researching HPV, its involvement in cervical disease and cancers, and opportunities for prevention. She was a past president of the Association of Clinical Microbiologists, which is now incorporated into the Association of Clinical Biochemistry and Laboratory Medicine, and a founder member of the International Papillomavirus Society. She was the first director of the National Reference Laboratory for HPV and the Scottish HPV Reference Laboratory. And in addition, she was awarded an MBE for her contribution to healthcare science in Scotland in the Queen's Birthday Honours in 2012, and made a Fellow of the Royal Society of Edinburgh in the same year. And most recently, in June 2019, she was appointed Chair of Scotland-Malawi Partnership. So thank you so much for joining me today.
It's a great pleasure, Martha. I'm delighted to be part of your science podcasts.
So to start off with, may you tell us a bit about your career?
So let's go right back to school. I was passionate about biology, but way back in the early 60s, you couldn't do all three sciences in secondary school. So I had to wait till my last year of school to move from physics and chemistry to biology. And then a lot of that got picked up at university. At university, I became really engrossed in microbiology and specifically viruses. So, okay, the 1960s is a long time ago, but an amazing amount was known, particularly about physical structures of viruses, much less about their nucleic acid. Because it wasn't really very long since nucleic acid structure had been properly unraveled, but it fascinated me. So I knew that I wanted to work in healthcare, but the jobs for clinical scientists were limited. Most of them were in biochemistry, actually, or medical physics. But I started my working life in pediatric pathology, and I learned about chromosome structure and to do antenatal diagnosis of chromosomal abnormalities. Loved it, but it wasn't virology. And what I really wanted to do, and this, quite often your choices have a personal element. And my younger brother died of leukemia when he was 17. And at the time, it was known that many animal leukemias were due to a virus. So you can say it's my brother's legacy that I ended up doing virology. And I went back into university when the opportunity came to work on Human Papillomavirus, HPV, because it was a tumour virus. So it linked, not leukemia, but a benign tumour, or so we thought. HPV was associated with warts on your hands, verrucas on your feet, but these are tumours where the cells of the skin grow abnormally. And so I did work on that, trying to find an in vitro replication system. And this is therefore now getting towards the end of the 60s, early 70s. Did some fascinating electron microscopy. So I know a lot about the structure of the virus. But most of the other things I did didn't work because we didn't know at that time how fastidious this virus was. And this is the lesson, a difficult lesson. After 3 years of very hard research, my work was not accepted for a PhD, and I got an MSc instead. Difficult to accept. Probably wouldn't happen these days.
No.
Probably happened I was a girl. It didn't matter to me in career terms. That was the attitude at that time. So I trained to be a teacher, biology teacher, but I only taught for a very short time. And when our oldest daughter was very small, I got the opportunity to work in a clinical virology lab. And through that, my role, because most of the people were either medical or technical, this middle group of clinical scientists was a tiny, tiny group. But it was my duty, and that's the exciting bit, to try and introduce new technologies into the diagnostic setting. And so I did, whether it was separating out IgM from serum so that you could look at very recent infections, whether it was finding new ways to culture viruses to get results more quickly, whether it was getting down to the molecular level, because I realized by then, because I kept an interest in HPV. Sometimes, the other thing that's important is that sometimes your first love actually stays with you. And so I kept being interested in HPV, but people would say it's not an important virus. But I realized that the only way we would know more about it would be if we were able to use molecular techniques. And the opportunity came for me in the 1980s, so quite a long time later, by which time people were beginning to think that HPV, or some forms of HPV, were associated with cervical cancer. A bit of a full circle. And the techniques were developing. So it was, and I did basic molecular and immunological work in the 1980s on HPV for a PhD. That time I got it. Went back into clinical virology, still not much opportunity to do anything with HPV because the clinicians didn't accept the kind of results we could get because the techniques were still too new. And if you think of all that's happened with COVID this last year, you can see how it takes time. It takes the evidence, the accumulation of the evidence to be sure that actually something is worthwhile and, in the case of HPV, clinically effective. So then I spent about 10 years fighting for an HPV reference lab, knowing that we had the tools. How could we use it? And during those 10 years, did a little bit of work on the antibody response to papillomavirus with Margaret Stanley, whose name you may have come across because she is very, very much associated with the development of the HPV vaccine. She's in Cambridge. As a consequence, I got involved in vaccine, and there were other people doing the development work. But what I had done up until then was sufficiently recognized that when there were discussions in the UK about whether this vaccine would be worth introducing, I was very much involved in the policies and the direction of travel. That was a very, very exciting time.
Yeah.
And the UK has done phenomenally well. We should be really, really proud of what we have achieved with HPV vaccine and with our of HPV disease. Not just cervical disease, but oropharyngeal disease and other anogenital cancers, which are also associated with HPV. So this virus is a true malignant tumor virus. Not on its own, it needs other things. As in most settings, they're multifactorial. And that's very, very true for HPV.
So can you tell us a little, sorry, carry on.
No, I think that's enough. Yeah, you please ask the question.
Okay. So can you tell our viewers about how HPV can cause these cancers that you mentioned. So you mentioned that there were other factors. Maybe on a more basic level, but what are these factors and how can they then cause these cancers?
Well, the first thing is, just like common cold virus, just like coronaviruses, there are a lot of different types of HPV. It's thought there are probably at least 200. And of those, only about 30 are associated with cancer development. So there must be something different about them. So there are different, they can be grouped, these 200 can be grouped into those that cause infection of your skin. That's the warts and so on. Those that cause infection on the mucocutaneous skin, that's where it's much less keratinized, because actually papillomavirus requires mature keratinocytes on the surface of the skin to be able to complete its replication cycle and produce lots of new infectious virus. So mucocutaneous skin is the skin that occurs inside your mouth or inside the cervix, inside your body in terms of the junction with the anus. So all these areas, the skin changes. And at each of them, there's a junction where the change goes from cutaneous to mucocutaneous. This softer, non-keratinized skin doesn't allow the virus to complete its replication cycle. So instead of producing lots of infectious viruses, it gets stuck. And if it gets stuck, some of the viral proteins are produced in abnormal amounts. And that's true for there are only 8 genes in a papillomavirus, and 2 of them, they're divided into early and late. So if I say L1 is the coat protein of the virus, and that's what's used in the vaccine. E genes are the early genes which help in replication, multiplication, and the development of new virus. E6 and E7 are called oncogenes. So what do you think the oncogene means?
I like cancerous.
And the E6 and E7 genes are different in different kinds of papillomavirus. So the reason they are able to cause the development towards cancer is that the E6 can bind to a cellular tumor suppressor gene called P53. And if it binds the thing that is suppressing cancer, guess what? The cells keep dividing. And then E7 comes along and interacts with another cellular tumor suppressor gene called the retinoblastoma gene protein. A bit difficult to remember, just remember E6 and E7. But it complements what E6 has done. And so you've got 2 things acting to promote cancer instead of producing mature virus particles.
Right.
And some papilloma types are much better at doing that. Their E6 and E7 genes are much more efficient than others.
Okay.
Does that make sense?
Absolutely, yeah, that's wonderful. So are there any differences between how HPV can cause something like cervical cancer compared to how it can cause oropharynx cancer?
To how it can cause what? Oropharyngeal cancer. Well, let's go back a little bit and think about what other things might be important. Although papillomavirus needs mature keratinocytes to complete a whole replication cycle, it needs the basal cells of the epidermis to start an infectious process. So how can a virus get into the basal cells? The easiest way is if you've got abrasions or micro abrasions, which happen all the time in your skin. So even thinking back to the very early days, verrucas were most common on your feet, particularly plantar verrucas, were most common in swimming pools, which had rough surrounds, stop you slipping into the water, and those rough surrounds macerate your feet together with all the moisture. It can get in to the bottom of your skin. The same is true even in the mucocutaneous areas. So let's take the cervix and genital areas where you've got far more of this mucocutaneous skin, not on the outside but on the inside. Then actually things like sex will cause microabrasions. And so if there's virus around, it can get in. Now, for many years, particularly in the 80s and before, it was thought that cervical cancer was actually, it was the husband or partner that was responsible for it, that they were transmitting the virus. The most important thing to understand about HPV is that it's a really ancient virus. It has learnt to live with us through millennia, not just men, women too. And this virus gets transmitted back and forward all the time, most of the time causing no problem at all. That's the most important thing. And that's the reason we can put out the right kind of messages about transmission, because it's thought that probably 80% of people, not just men, people who have ever had sex actually will have had an HPV infection. That only a minute proportion will go on to develop cancerous changes.
And that's really important, because
and so you need other things.
Yeah, not many people know this. So we need to have better education in schools, I think, probably.
To me, it's the most important message of all. And if you, through your podcasts, can transfer that to your peers, I've always wanted to try and have more peer education opportunities, because I think it's you young people who need to teach each other. So a really, really common virus, because it's learnt, because I'm sure you know that a virus, yes, is a parasite. Well, it's not really a parasite, it's a commensal, because most of the time it's trying to learn to live with its host. If it kills its host, then it's not going to survive itself.
No.
So the most effective viruses have found ways of not doing too much damage. So that's why we know that.
So
you've got another question.
Your involvement in the HPV vaccine, can you tell us a bit about what kind of vaccine this is, or are there multiple types? And how, I mean, people will have heard about the COVID vaccines and how these all work, so I'm sure they can link the things together. Yes,
I think the learning process for everyone has just gone up and up and up this year. That's one of the outcomes, the positive outcomes, if you like, of a horrible pandemic. So, okay, take you right back to what I said at the beginning, that I spent my early years in research trying to find a way in which to grow the virus in the lab, and they didn't work. So this is not a vaccine that can be grown in cell culture. In the virus, you can do it, but it's so complex. You need to create artificial skin, basically, with all the differentiated layers. And to do that in the lab is very difficult, very expensive, and would be very difficult to scale up. But we do know, because it's a small virus, we know its sequence. there are only just around 8,000 base pairs in its genome. That's tiny, really tiny. 8,000 relate to about 8 genes. And we now know which are the relevant genes. So do you remember I said L were late proteins?
Yeah.
So L1 and L2 are the only 2 protein gene products that are associated with the formation of a mature virus particle because they form the coat. Our immune system reacts to what it sees. And so if you could engender an immune response to those proteins on the outside, then you would have a good vaccine.
Mm.
And this is similar to many others. It was possible to create virus-like particles, VLP, by putting the L genes into a vector, like adenovirus. In fact, actually, it's an insect virus, and papillomavirus is the virus that is used for at least one of the manufacturers, and in the other case, it's yeast. And you put those genes, so the papilloma L1, onto a vector into cells that will produce mature particles, but they're mature particles without any DNA.
Mm.
And these proteins self-assemble. I mean, nature is wonderful. And the structure, the three-dimensional structure of the molecules is such that they form a whole virus particle, but it's minus the nucleic acid in the middle.
Mm.
And at some point, if you like it, I can share pictures with you of an infectious particle and a virus-like particle from the electron microscope. Yeah, I'll do that afterwards. I'll send that to you.
Oh,
you
wonderful.
So all the HPV vaccines are based on virus-like particles, VLPs. Mm-hmm. So they're all genetically engineered vaccines, so there is no risk of infectivity from them. Some of your childhood vaccines are what are called inactivated virus, which means it's real virus, which has then been killed. And occasionally, the killing is not absolute, so you get an issue. Mm-hmm. And as you'll have heard in the recent weeks, no vaccine is 100% effective. But actually, I have to say HPV vaccine goes a long way along that road.
Amazing.
So there are currently 3 vaccines on the market.
Okay.
One is called Gardasil, and it's got 4 different VLPs in it to type HPV 16 and HPV 18, which have been thought to be the most oncogenic, the most likely, the most frequently associated with cancers, whether it's in the cervix, the anus, or in the oropharynx. So HPV 16 globally is, and it's considered to be a much stronger carcinogen than nicotine, which is another good thing to think of. So the Gardasil 4 has got HPV 16, HPV 18, HPV 6 and 11. Those 2 are associated with genital warts. Now, genital warts are occurring on the outside. They are on cutaneous skin, and they don't cause cancer, but they like that environment more than the HPV types that are associated with hand and foot warts. They're just a little bit different, but not as different. So the vaccine was produced as a way of reducing what was the most common sexually transmitted infection, genital warts. And that was produced by a company called Sanofi Pasteur in the UK. Merck is the global name. But there's another company, just as we've got companies with COVID vaccines, producing them slightly differently. And GSK produced a vaccine called Cerverix. Cerverix only contains VLPs to HPV 16 and 18, so it's only got 2 in it. But the evidence over the years, and it was manufactured as a cervical cancer preventing vaccine. So it was only licensed for girls, and it wasn't meant to do anything with genital warts. That made it easier when the messages about sexual transmission were not so well understood. So the UK started with Cerverix in 2008. But in 2012, they changed to Gardasil, Gardasil 4. So depending when you got yours, that would depend which of those 2 vaccines you got. And they changed partly because there was a growing lobby to be able to vaccinate boys as well as girls, which, as you probably know, started last year. But the evidence, as time went on, showed something slightly different.
Okay.
It showed that while it didn't really have much effect against genital warts, the Cerverix, the bivalent vaccine, was actually more cross-protective against a wider range of HPV types, not just 16 and 18. And that's thought to be partly due to the fact that they have a trade secret adjuvant. Do you know what an adjuvant is?
I don't.
In a vaccine? It's a chemical that is added to stimulate your immune system. And because the L1 proteins are all very similar to be able to form the same kind of virus particles, this extra stimulation seemed to give some cross protection against other HPV types, related HPV types. And that becomes quite important globally, because while HPV 16 and 18 may be the most important in Europe and North America, what we might call the Western world, they're not the most common types. 16 is still the most common in cancers, but they're not the most common types in precancers, and 18 is definitely not anything like as common in many countries. So in recent years, Sanofi Pasteur, Merck, have produced a second Gardasil, and it's called Gardasil 9. To overcome this, they've got 9 different virus-like particles in one vaccine. It's like giving you 9 vaccines in one shot. And of course, there were concerns perhaps that would overload your body with foreign protein. But it is working, and it is being used, but it's still quite a lot more expensive than the Gardasil 4. There are other companies in India and China developing vaccines a little more cheaply, because in the early 2000s, this was the most expensive vaccine ever produced.
Oh, wow.
I don't know how COVID vaccines compare in terms of the development costs. But that's probably almost enough detail, except one other thing. You probably got 2 doses of vaccine, or did you get 3? Do you remember?
It was quite a while ago, but I'm sure I have the paperwork. I can find it.
Well, worth it. So it started off, you had to have 3 doses, time 0, time 1 month, and at a year. Doesn't that too sound familiar about all the discussions with COVID vaccine?
Absolutely.
You know, that the US has increased the interval between dose 1 and 2. Oh, surprise, surprise. With the HPV vaccine, they were able to reduce it to 2 doses, which are now 6 to 12 months apart. Much easier if you're delivering it in school, because the disruption in school when there were 3 doses was considerable. And in low-income countries, there's a lot of work going on to see if it can be reduced to 1 dose.
Oh, wow.
That would be affordable.
Mm. Wonderful.
And the same will happen with COVID.
Yeah, definitely. So can you tell us a bit about the testing, the different types of testing for HPV? So I know that there's like an in-house ELISA test to detect anti-HPV 16L1 antibodies, as you were talking about. And this is in serum and dried blood spots. But this might be used for monitoring how well a vaccine has worked. But then also there's some concern surrounding treating samples with glacial acetic acid. So can you tell us about that?
These are very different. Okay, those are two very different things.
Okay.
So let's take the antibodies. So the ELISA tests are antibody tests used for many, many viruses. And so my thinking way back in the 80s was that we use antibodies to tell us about infection, past infection or present infection in other settings. Well, it was at that time quite hard to make the VLPs because you needed those for the ELISAs as well. Obviously, vaccine manufacturers are much better at it. But these days, it isn't the simplest test to use. So there are very specific situations where you would look at antibodies to HPV, and you're quite right. Surveillance of the effectiveness of a vaccine is one of them. So there are relatively few places can do the antibody tests, and the vaccine manufacturers have probably done the bulk of them, and one or two other laboratories that they work with. But it's where molecular detection came into its own. And so the early techniques were in situ hybridization. So if you got hybridization between one strand of DNA and the other strand, a complementary strand, well, and you knew the sequence of this virus, you could make a complementary strand. And that's what synthetic oligonucleotides are. That's also what primers are for the much more commonly used PCR-based test. PCR stands for polymerase chain reaction. So as well as this infectious nucleic acid and a primer, you add an enzyme which lets this reaction of hybridization go on again and again and again and again and again. So it amplifies your result because there's tiny, tiny, tiny reactions that are happening that you have to amplify it. So you have to, first of all, break up your infectious DNA, add your primer, your synthetic oligonucleotide, add the enzyme, let it do its work, and then break it all up again. And then together again. And every time it's an exponential increase in the number of hybrids. So you then have to have some way of identifying that the hybrids are there. And that might be a color reaction. And that's what happens in the ELISAs for the antibodies as well. So there's some bits of the technology are actually similar. It depends on the system. There are lots of different ways of identifying the amplimers, as we call them, the amplified fragments in PCR. So most tests are based on that, on PCR. Again, like the HPV types, there are more than 200 HPV tests on the market. Most of them have not been adequately clinically validated. There are only perhaps a dozen or so. In big trials, comparative trials, using the first test that really worked as a gold standard and measuring new tests against it. And that's ongoing all the time and is a real function of a reference laboratory.
So can you tell us about this, the concerns surrounding the glacial acetic acid?
Yeah, that's a minor thing in all the other questions you've been asking. You may know that cervical screening in this country has been based not on HPV testing, which is the cause, but on cytology screening, looking at cells taken as a scrape from the cervix. And those superficial cells may show virus-induced changes, or they may even show cancerous changes. That's the whole point of cytology, and that's what happens in pathology screening laboratories. In order to see the cells clearly under the microscope, the scrape is often treated with glacial acetic acid to get rid of blood and mucus. And then you see the cells under the microscope clearly. But that glacial acetic acid, and the beauty of taking a sample, which is a liquid sample, you can do the molecular testing as well. But if you've treated it with glacial acetic acid, there's been a concern that that will reduce the efficiency of your molecular test.
Okay.
But, as you possibly know, the screening programme in the UK is turned the other way around. The sample that is taken in the clinic is tested for HPV first.
Yeah.
And the positives are given cytology. Whereas up until a year or two ago, it was the other way around. So that the glacial acetic acid is no longer a major problem.
Yeah. So you spoke a bit before about the E7 protein. So one of the most established biomarkers is P16, which is a cyclin-dependent kinase inhibitor, and it essentially regulates the cell cycle. So high-level expression of this E7 protein can upregulate P16, so levels of P16 correlate with increasing grade of disease. So how has this discovery aided your work?
So it's not an area that I've been very much involved in. Yes, I've worked with the pathologists, but it's the pathologists that do the P16 testing. It's done by what's called immunocytochemistry. So they have their, let's say, a biopsy section. You can do it on cervical cytology samples as well, but it happens in a different lab. And so it wasn't a major part of my work, but I always worked with pathologists. So it's been a much more relevant thing in looking at the oropharyngeal cancers than it has in the cervical cancers, because it seems to be that if you've got enough P16 upregulation and an HPV positive test, then that's bad news. Things have progressed further. Because remember, if we're talking about cervical screening and looking at HPV first, remember the very first thing I said about 80% of people having an HPV infection, but most of them don't go anywhere? Well, you get an awful lot of positives in screening, which aren't significant positives, because those positives will disappear when your body clears the virus.
Yeah.
And again, you probably understand this better because all you've heard about COVID, the timing of when a test works and the importance, the significance of that finding. So if you take the lateral flow tests, which we'd love to get to with HPV, and probably that work was ongoing, but has been stopped to move over to COVID. The lateral flow test only works when there's enough virus there, which is why you can get a false negative too early in an infection or later in an infection, whereas the PCR is much more sensitive. So different tests have got different, really different uses in different settings. And you need to understand the setting well to be able to make the right choice of test.
Absolutely.
And so the P16 is used when it's felt that it will be an extra help. So one of the ways that you might use it now, if you do HPV first in screening, but you get a lot of positives that aren't, I'm not going to call them false positives. They're not false, but they're not significant clinically. But you want to look at what's called a triage test, the next line of testing. So we would do cytology. But you can do P16 staining on the cytology slide. So can you get a much better risk assessment of the people who are desperately in need of treatment?
Okay. So
Does that make sense?
Absolutely. So to finish off, you've carried out research focusing on Malawi as a low-income country into the delivery of cervical cancer detection, treatment, and complete pathways of care. So first of all, what did you find? And then we'll move on to the fact that they may need alternatives in this area.
Absolutely do need alternatives. Okay, where do you think the burden of cervical cancer is greatest?
In these low-income countries?
Absolutely, by many, many factors. Ours has been reduced hugely in this country because of two important interventions: vaccination and population-wide cervical screening. Anyone who doesn't take up their opportunity for cervical screening when it's free, in my view, is crazy, because most countries it's not free. So low-income countries do not have good vaccination yet, most of them, and they do not have comprehensive screening. So we've talked about the two screening things, cytology and HPV. Both of those are very expensive. Now, in a country like Malawi, there is something like half a dozen pathologists for a population of 18 million. There's no way they could ever introduce cytology. And an HPV test at something like 10 to 15 pounds is more than they spend per year per person on healthcare. Not going to work, is it? And yet they have got the highest burden. So we thought that we could take Scottish expertise, which covered a whole lot of things, whether it was the vaccine delivery and the surveillance of vaccine, whether it was HPV testing, which was probably the first starting point, whether it was our way of doing screening, or whether it was our way, in parts of Scotland at least, of treating early lesions, the pre-cancers. And all of those are things that to say we've taken to Malawi is actually implies we've done more. The whole point has been to empower Malawi to do it itself at minimal cost. And it's been we've talked about my passion of virology and HPV. I have to say, this is probably the climax of my career, because we now have, we have ensured since 2013, that about 72,000 women have had a screen who would never have had a screen. And we're not using cytology. We've tried to use HPV, but it was too expensive. We're using what's called visual inspection with acetic acid, slightly different from the glacial acetic acid in the lab. Visual inspection is called VIA. So someone actually puts in a speculum into the cervix and has a look at the cervix, the health of the cervix directly with the help of a torch. And if you apply a cotton wool swab with a 5% vinegar, which is acetic acid, onto the surface of the cells, if there's an abnormality, they turn white.
Okay.
So you can become skilled at recognizing these white lesions as being potentially dangerous. VIA has had a bad reputation in many places because it is a real skill to keep up that, to be able to differentiate. So we set up a program where the people who were carrying it out, not doctors, not pathologists, but clinical officers and nurses, really learnt and kept learning by seeing enough women. And so they were continually being skilled. Now we do the same in the UK, except we use a colposcope, and a colposcope is a microscope which looks into the cervix. They're having to do it without the colposcope. They're having to rely on their eyes. So there are still people around globally who would say it's not good enough. But there's a lovely phrase, my husband taught it to me many years ago: the best is the enemy of the good. Think about it for your future. And we know we can do a lot of good with VIA when it's done properly, even if it's not the best if you had limitless resources. So screening by VIA, they will eventually get HPV testing. And I'm involved in other projects in other countries to try and bring the cost of that down and do it in a way that actually would work for these countries where women can't go back easily for other appointments. It costs them a lot to travel to clinics. And the second thing was Malawi already did have the strategy for a VIA program, but it didn't have treatment available. And basically, it's unethical to offer screening for anything if you can't do anything about the people that need help. So the important thing was to introduce some kind of treatment that could be done on the spot by the people who were doing the screening, all in one visit. Well, that doesn't happen in this country. You might take 6 weeks to get any treatment. So we introduced a treatment called thermal ablation, which can be, it's like using heating to kill the cells on the surface. You need a special probe, you need a power supply. That power supply can be solar or battery these days, and it turns the lesion. You can see that it's being effective because it will change the color of it. Okay. And it can be done there and then if you've trained people. So about 70% of the women in Malawi who have needed treatment for pre-cancers, not the overt cancers, which need much more sophisticated surgical or chemotherapy or radiotherapy, of which Malawi doesn't have. So the important thing is to catch the early lesions and prevent them developing. So about 70% of those that needed treatment for early lesions have had it on the same day. Amazing. And these are successes. We now have, coming on towards 100 trained providers in different parts of Malawi. And the Ministry of Health there knows that actually women are being well informed, and I'll come back to that just as the final thing, but that this could be affordable. The equipment is no longer expensive, and we've supplied equipment, but which lasts decades. So we hope that when we finish in 2023, the project will just carry on. And that would give something sustainable, which would just be wonderful.
That would be amazing.
And so the final thing is about information, and it comes back to something you said right at the beginning about education of people, whether it's your peers or people coming to clinics. So what do we do in this country? We give people information leaflets. We say, look on the web. Some people can do that, but many of these people, most of them certainly wouldn't have access to the web. And many of them are illiterate. So every clinic, the start of every clinic is a talk, sometimes translated into songs because they learn by singing the messages. And we got some student nurses to write an HPV song for us. And actually, we think these women are probably more knowledgeable than UK women, because they all hear it. They get a consistent message. That was one of the things we wanted to make sure everyone, all the providers, gave the same story. They might have to answer different questions because the women do ask lots of questions. Do we ask questions of the leaflets? Almost never. They go in the bucket very quickly. So I think we've got quite a lot to learn from countries where healthcare has to be done at a very different resource level. And we could save a lot of money and therefore use it in different ways. And that would be a wonderful thing.
It would, it definitely would.
Lots, Martha, probably much more than you wanted me to. You
No,
can prune out as much as you want.
Amazing. Honestly, that was wonderful. Thank you so much. I really, really appreciate your time. It's been really wonderful. It's
a great pleasure. And I'm very happy to send you some images that you can then put in if you want to, or have for your own use.
That would be great. Thank you so much.
And feel free to come back to me if there's anything else.
Thank you. Thank you everyone for listening.